Hi, this is Jeff Anderson, Secretary of KDHE. We just finished another one of our KanCare member education meetings where we're answering questions for those who want more information about the KanCare program. We have more meetings coming up in October. Also, you can go to kancare.ks.gov for more information, whether you're a provider or a member in our KanCare program. Thank you.
I'm Carrie McMahon from the Community Engagement Institute at Wichita State University, and I've got several of my colleagues from Wichita State here as well to help out with our process today. They're all waving their hand and saying hi. So if at any time tonight you need some assistance, don't hesitate to snag one of them, and they'll be happy to help in any way they can. The Community Engagement Institute is a university center that's partnered with KDHE to help with stakeholder engagement. So we're really here to help make it an easy process for you to give feedback and ask questions of KDHE tonight. So today we're here so that the state can provide you some information about KanCare Open Enrollment that's coming up, and also about the change in MCOs that's happening, so that they can share with you a little bit of information. And so their presentation is going to be pretty short. And then we will have plenty of time for you to ask questions about what's happening, and hopefully get answers to those questions. We do ask that you keep in mind that some questions we might not have an answer for you today. We are going to take down all of the questions that are asked, and the state's going to work on putting those together into a frequently asked questions document. So be on the lookout for that. And there will be other opportunities for you to ask questions later on. So those answers will be coming down the road if there is something that we don't have information for you on tonight. As far as what to expect today, like I said, we'll have a really quick presentation from KDHE, and then we'll use as much of our remaining time as we need to for you to ask your questions and help get those answers for you. We've got up to 2 hours. So if we get through all of your questions, we'll end early, but if we need to, we will stay for that full time for you. After the presentation, we do have, like I said, the state staff here, and they're willing to hang out if they need to talk with you one-on-one to answer your questions as well. So with that, I'll hand things over to Becky Ross, the Medicaid Initiatives Coordinator at KDHE.
Thanks, Carrie. I'd like to thank you all for coming out tonight and giving up some of your time to meet with us. As Carrie said, we're here to present some information and then answer your questions. I would like to introduce our state staff. We have several folks here. Up at this table, we've got some state staff, both some folks from KDADS, Brad Ridley and Melissa Warfield. We have Russell Nittler, who's our eligibility expert, and Claire DeLeo, who is an MCO manager. Over here we have Jennifer Crawshaw, who's a provider and customer relations person. And in the back we have Secretary Anderson, the Secretary of KDHE. And then up at this table we also have Mark Woodring, who is our Director of Policy and Operations. So as Carrie said, if we don't get to all your questions, or you have a particular personal question, particular instance, come see us after we finish, and we'll try to get you an answer or get some information to take back to get you an answer. So we just have a real quick presentation. Just a reminder, KanCare provides services to over 400,000 people. So it's a big program. And we cover a variety of folks, so pregnant women, children, seniors, and people with disabilities. All the services are provided through managed care organizations to make sure that those services work well for you and that everything's well coordinated. We try through the program to emphasize wellness and avoiding health problems before they happen. You should all be familiar with the KanCare MCOs that we have today. Our first contracts when we began the program were with AmeriGroup, Sunflower State Health Plan, and United Healthcare of the Midwest. we're required by the federal government to procure contracts regularly, so they don't let us continue to have contracts with the same managed care organizations without doing a new procurement periodically. So we did that. At the tail end of 2017, we issued a request for proposals, and we received bids on that. And we had a number of staff working on both that request for proposal and on reviewing the proposals that came in and making recommendations as to which MCOs to contract with. So beginning in January 1 of 2019, we will be contracting with Aetna Better Health, Sunflower, and United. So you can see AmeriGroup is no longer an MCO that we'll be contracting with after 2018. So what's covered in KanCare? You're still going to get all the services that you get now. We require the MCOs now and in the future to cover everything that we tell them to cover, and that is in our Medicaid state plan. So all the services that are currently covered will continue. And that includes your doctor's visits, hospital visits, treatment for mental illness and substance use disorders, your drugs, for folks who need it, nursing facilities, transportation, and other services that you're getting now. You can still choose your KanCare health plan, and we'll talk a little bit about that here in a minute. You can choose your doctor. You can change your doctor. If you have a doctor that you need that isn't available in your hometown and you have to travel to go see that doctor, the health plan must provide you transportation. Okay? That's what we call our non-emergency medical transportation. Some other protections that you have in KanCare include that you'll have a member advocate that will help you file a complaint if you have a complaint with an MCO. Each MCO also has to have a group of members to advise them. They have a member advisory council, and you can find out more about that by talking with your MCO or looking in your member handbook. You will be asked how you like your MCO. We do surveys. The MCOs have to do a survey every year and survey a sample of members and report that to us. There will still be no co-pays for your regular KanCare services. The basic dental care that was provided in KanCare through the MCOs, the adult cleanings, will continue. And of course, children also get some other dental services. There'll be some improved service coordination later on in 2019 to help people with serious health problems and complex conditions. We're still requiring the MCOs to bring what we call extra services or value-added services at no cost to the state. So those dental cleanings that they provide for adults, the state doesn't pay for. The MCOs bring those services, pay for them themselves. There's others of those services, and hopefully you're familiar with some of the ones that are occurring today. There'll be some new ones coming in 2019. They'll be the same providers, same services. So your services will stay the same, your Medicaid ID number will stay the same. You'll still have the right to appeal, to file a grievance, to have a state fair hearing if you have a dispute with your MCO, and you have the right to choose your MCO every year, and we'll talk more about that. So if you're an AmeriGroup member today, what that means is you will no longer have AmeriGroup in 2019 because we're not contracting with them, okay? Aetna will be the third MCO. What we will do is temporarily assign you to Aetna, and later this month, you should get a packet of information that will tell you that. It will also give you information about how you can change if you don't want to be with Aetna, and how you can choose one of the other two MCOs. If you want to stay with Aetna, you don't have to do anything. But if you want to change, you can call or fill out a form, and that will be part of your packet. So if you're an AmeriGroup member now, you should continue to get services through the end of this year from AmeriGroup. They can't change how they provide services. They're contracted with us and obligated to provide those services through the end of the year. In October or later this month, you should get that packet with the letter that will tell you that you're going to be assigned to Aetna starting in January. And again, if you don't want to switch and you're okay with trying Aetna, you don't have to do anything. But if you want to switch, there'll be information in the packet that will tell you how to do that. You can choose any of the plans, any of the 3 plans that are available. So Aetna, Sunflower, or United. Now what will change for everyone is that everyone will eventually get an enrollment packet. So even if you're not with AmeriGroup and you're with United or Sunflower, you'll get an enrollment packet. And the letter will say you're currently with United or you're currently with Sunflower, but you have the option to choose a different plan if you want to. You don't have to, okay? You can continue to be with either Sunflower or United. And again, you'll have a letter there telling you that. There'll be a phone number you can call or a form that you can turn in, whichever you're more comfortable with. If you want to just pick up the phone and say, I want to switch, that's fine. If you want to stay with the plan that you're already with, you don't have to do a thing. You will have until April 3rd of 2019 to make your choice. So if you want to, you can switch several times in that time period. And we'll be coming out in October to talk with you again about it. We'll bring one of those enrollment packets and show you what it looks like and talk you through all the information in it. But of course, one of the things you want to look at is, are your doctors and your medical providers with the particular plan that you want to select? What are the value-added benefits that that plan is bringing? What are the extra services that they're bringing? And are any of those going to be useful to you? There will be a phone number and a form in your packet, and you can use either one to make your choice. And again, you'll have until April 3rd of 2019. So some of the new extra services that will be available. Right now, the MCOs offer that basic preventive dental care. They also offer cell phones or extra minutes on cell phones. They provide ways for you to earn points that you can spend on health items. They provide help to quit smoking. Some of the new extras that will be coming in 2019 include extra help for people who want to move from the nursing home back to their community. Some extra help for children in foster care and their families. For some HCBS members, there'll be some extra transportation services available to go to social events or to help them get to work. And one plan is even offering free internet access as a reward for healthy activities. So when you get that enrollment packet, there will be a table in it that has a side-by-side comparison of the value-added services or those extra services. So you'll see what Aetna's are, what Sunflowers are, and what United's are, and you can make a comparison. Because that's one of the things you should use to make the decision as to what plan you're going to be with. So we'll talk more about those October meetings here after we get done with the questions, but I'll turn it back over to Carrie so we can get started on the questions.
All right, so a lot of information about what's changing and what isn't. So thank you for sharing that information, Becky. And we'll go ahead and get ready to open things up to hear from you. And again, we really want to focus on hearing your questions about the information that was shared this evening, about the change in MCOs, about open enrollment getting ready to start. So we've got Vincetta and Zane with microphones, and they're going to bring a microphone to you if you have a question. So please do wait to ask your question until we have a microphone so we can make sure we and everybody else can hear you. We do want to make sure we can hear you and get you the right answer for your question. And as you can see, there are a lot of people, so it will take a little bit of patience for them to make their way around the room. And we do ask that you ask your questions one at a time, and we just want to make sure we have time, we can let everybody who wants to ask a question. If we come to you and need to come back, that's perfectly fine. We just want to make sure we have time to talk to as many people as we can. And like I said before, we've got plenty of time to talk and hear from you. So with that, we'll go ahead and just, if you've got a question, you can raise your hand and set it up here at the front, and we'll get started.
Thank you very much. My son is an AmeriGroup member. He has a Medicare Advantage plan, so his MCO picks up the copays. And my question is, he has a number of services, physicians, doctors, clinics that are in the network for AmeriGroup. Will he still have those same doctors, clinics, and organizations available in either the Sunflower, United, and Aetna?
For the most part, our three MCOs have very similar networks. There's a few providers that are not in all three networks. So that is one thing to look at. Oh, sorry. That's one thing to look at when you get that open enrollment packet, and call the number at Aetna and say, you know, these are his doctors. Are they in your network? And you can do the same thing with Sunflower and United today. You could call them up and just ask, are these doctors in your network? You don't necessarily have to be a member to ask that question. But we are expecting those MCOs to have robust provider networks. They have to by federal regulation, and so we'll be monitoring that to make sure they have adequate networks. But that is one thing you'll need to look at when you determine whether or not your son's going to be with Aetna or move to one of the others. Are all his providers in their network?
Can I ask just a quick follow-up, please? So this is something that I can find out by calling each of the MCOs, or I guess I could go to the physicians and say, do you have that? And the primary concern, of course, is his primary care physician, who he's had for 12 years.
Yeah, so yeah, that's another good way, is just ask the providers. You can also go online. Each of the MCOs has their provider information online, and you can plug in the provider name or other information, and it'll search and let you know if that particular provider's in their network.
Thank you.
I did forget to give one quick reminder before we get the next question. I apologize. I did want to mention at the back of the room, we do also have a representative from the KanCare Ombudsman's office. So again, if you have a question or a challenge, Carrie's waving her hand back there. If you have a question or challenge that's unique to you that you need assistance with, or maybe that's not quite related to our topic today, feel free to talk to Carrie or any of the other state staff after we wrap up here. That way you can get that one-on-one attention and talk a little bit more in depth about your situation. So, okay, Zane, I'm sorry, go ahead.
Could you tell me if Aetna, as a new MCO, what their track record has been as a managed care provider for long-term care and services for HCBS clients in the United States?
They are in the Medicaid program in 23 states.
I mean, not as a medical model, but as a long-term care residential day service provider MCO.
Well, that was one of the things that we looked at in their proposal, and they have experience with that in other states. So they're used to providing those services for that population.
Thank you for your question. And Vincent is also up here at the front of the room.
Hi, I have a question about the dental coverage. It says it is included, but I've had difficulty finding a provider that actually accepts it. Any suggestions?
Well, I don't think it's any secret to people who live in Kansas that know, first of all, we have a shortage of dentists, period. We also have a shortage of dentists who take Medicaid. We hope that the MCOs will continue to try to build that network. I will say that one of the things that United is doing is they're actually moving away from the 2 cleanings and an x-ray a year to basically giving, I believe it's a $500 benefit for anything. So it could be for cleanings, fillings, whatever. That may be more useful to folks, and it may actually attract more of the dentists. But we're constantly pushing those MCOs to get out there and try to get more dentists into the network.
Will that start in 2019?
Yes.
Her follow-up question was whether, that was whether that dental benefit that Becky was talking about would start in 2019. And I think just for ease, we're gonna have to start at the front of the room and work our way back for questions. So I see the hands in the back, and I promise we're coming back there. And then you have our next questions?
Yeah, mine is pretty simple. Once you enroll in KanCare, do you have to re-enroll every year if you don't change anything?
Are you talking about choosing a plan, an NCO, or are you talking about eligibility?
Eligibility.
You do have to, there's a review process. And so you should receive a packet of information, telling you that your review's coming up and return information from that packet. If you have a specific question about that, see this gentleman in the blue shirt afterwards.
Vincent, you have our next question?
Yeah, this question is on behalf of my mother. She has a merit group. I just want to understand a little bit more about the enrollment. Would it be correct to say that in October they will pre-assign Aetna? So come January 1st, they'll just flow into Aetna. And if that plan suits my mother, she can just continue with that where she doesn't have to do anything further? Or do we have to do something by April?
No, if Aetna works for your mother, you don't have to do a thing. I would advise you to take a look at the information in that enrollment packet, because there'll be information about Sunflower and United as well. Make sure that her doctors are going to be in the network. If there's value-added services that meet her needs, with Aetna, then you're good to go. But any time from getting that enrollment packet to April 3rd, you can make a change.
More of an answer than a question. We happened to ask our dentist over in Topeka, and she sent us to as a dentist, Dr. Fassbinder. Excellent doctor, because my son would not even open their mouth. And now he wants to go back and visit and everything. Of course, you have to see my son. But he's a go-getter. I thought, we're wasting a trip to go to Kansas City to get him. But he now has cleaned his teeth. He's talking about fillings. And he gets them on their level. And basically, most of the patients that I've seen with him have some type of need. So it's Dr. Fassbinder, and he's Kansas City.
Thank you.
Yes, he's been with the Medicaid program for a long time.
And Vincent has got our next question.
I have a question about Working Healthy with, are the prices going to go up with Working Healthy, or is it still just based on the income?
No, that should stay the same. Your premium, that's not going to change.
Hi, you mentioned the issues with provider capacity with dentists and the fact that the MCOs have to provide an adequate network. Similar issues with behavior analysts for children with autism, that there simply aren't enough providers that are contracted with the MCOs to provide the services to the number of kids that need the service. Can you comment on what actions the state's taking to address that?
So I'm Brad Ridley. I'm with the Department for Aging and Disability Services. So we know there's an issue with autism providers. About a year or so ago, there was some changes that opened that service up to those services up to more kids than exist prior. So we are working closely with the MCOs to look at the network, look at where there's gaps in the network. We're trying to come up with new ways to monitor what we would consider network adequacy. And some of that will be changing also on January 1. There's new federal requirements that require us to better monitor HCBS network adequacy. So we'll have several efforts moving forward to address the autism network issue as well as some of the other HCBS services.
I'm sorry, what's your name again?
Brad Ridley, and I can touch base with you afterwards.
Back. Right, then set us towards the center of the room.
Yes, I have a question for nursing home care, and I'm a durable power of attorney for my brother. And this is an eligibility question for that. And he had community care, KanCare, and he got sick, very sick, had to go to a nursing home. So they said that would slide over to nursing care. Well, that was almost 6 months ago. I just wanted to know, and we haven't heard anything. I wanted to know what is the rationale for for the two types of eligibility? I mean, how can you have one and not have the other? And secondly, how long should a person wait or think it should take for that to happen?
Okay, so your eligibility for HCBS, that community care that he had before he went into the nursing home, is the sort of same standard for nursing home eligibility. So if he was getting HCBS eligibility, his eligibility into the nursing home should be rather smooth. There's a form that the nursing home would need to fill out called the 2126 form. And then once the KanCare clearinghouse gets that form, they'll change the coding. So you might want to see me afterwards. I'll get your name and phone number and check on it to see if it's just not done or if something happened.
Well, all that has happened, and I guess I was just wondering, and they check up every 2 or 3 days, and they've been told that what happens is if something, little thing happens, it gets kicked to the bottom, and then there's 45 more days on the list that it takes for them to deal with it. And I just don't think that's very efficient, let alone compassionate.
Yeah. I would invite you to stop by afterwards and we can talk.
Same.
So I have a question about the targeted case management. What changes are happening to that with the IDP waiver? We're hearing about community service coordinators that are going to be from the MCOs. So what exactly is going on there?
Well, nothing will be going on until mid-2019. Service coordination will continue as it is, and targeted case management will certainly continue as it is. Starting in July, we hope to phase in community service coordination for certain populations through the beginning of 2020. The IDD population will be the last population phased in. And before we implement any of that, we'll be pulling together a group of stakeholders to talk about how that should look. And the MCOs and the state will be involved in training and oversight of the community service coordinators and what they need to be able to do. But we're hoping that that will be a more robust service than targeted case management, which is a fairly old service. And the federal government really limits what targeted case managers can do and get paid for through Medicaid. So we're hoping that through community service coordination, we can broaden that so that they can do more things and get paid for it.
Who's going to be a part of those stakeholder groups?
Family, members, providers, anybody who's a stakeholder. And we'll be pulling that group together probably later this year, early next year.
Thank you for taking my question. The question is, I have married group, and I have services scheduled out to December and even January. So do I need to go in and explain to them I've got a new insurance company coming and see if that's what I need to do? Or I guess the question is, what's the last scheduling you can do for Amerigroup?
Amerigroup is contracted through December 31st of 2018. So any service, procedure, anything that you have through the end of this year will be covered as long as it's a service that that we provide. For things in January, I would be talking to your provider and asking them, number one, have they been contacted by Aetna, because Aetna's out, contracting with providers, and also ask them, are they contracted with the other two, United or Sunflower? But through the end of the year, AmeriGroup should cover any service.
Hi, Brad, this question's for you. I know what Mike just asked about for the behavior specialist. My son's 23 and needed behavior specialist, has autism, and AmeriGroup, nothing. And I had to pay out of pocket for help. So luckily I was able to do that. So we have to look at not just kids, but adults, because once you turn 18, still have autism, still have behaviors.
Yep.
So, so that is what I want to make sure you have on your radar, please.
Sure. And I might follow up with you afterwards, get a little more detail on your AmeriGroup situation.
Oh, okay. And then the other side of that is, when you're talking about new care coordinators, will we even be contacted by our care coordinators? Because that is a revolving door with AmeriGroup I have had since it started. And, well, mine's with AmeriGroup. I don't even know who mine is right now.
Right.
Because they've never contacted me.
Yeah, so one of the changes Becky talked about a little bit ago, community service coordination, that's one of the issues that you just talked about, we've been hearing for years. So what we're trying to do is get community individuals involved in that care coordination and share that responsibility with the MCO so that we can have local folks similar to what exists in targeted case management, but have those local folks that can work more closely with folks and so people know who their community service coordinator is.
So who's accountable for that? Not just AmeriGroup, you all are accountable for that, correct? Okay, all right, just want to make sure somebody is accountable because we keep getting shifted, and it's extremely frustrating.
Yeah, and we are accountable, and that's one of the reasons we're making that change so that we can address all those issues we've heard.
So it looks like he's moving to the next person with a question.
Yes, my name is Kirsten Snide, and I have a son severely autistic who has seen Dr. Fastbinder. I guess my observation is that I'm hearing about these agencies that have available services, but that does not equate with the accessibility of them. I think the elephant in the room is that the reimbursement for our medical, psychiatric, dental community is abysmal. Dr. Fastbinder will be retiring. He does one of the few in our state that does sedation for those that are severely disabled. And as a parent, and as a stakeholder, and as a citizen, I expect better care for our loved ones. So when we talk about these agencies, we really need the boots on the ground. The waiting list for services, even dermatology, after a reaction, a bad medication reaction and hives, having to go to an emergency room, but are having a 3-month waiting list to be seen in a dermatologist's office. That doesn't work for our population, much less the neurotypical population. So we've got to find some way to really make that connection, because having available services does not make it accessible to me. Thank you.
Will the nursing homes be aware of the dental coverage that will be coming about in 2019? My mother's in a nursing home, and I just wondered, do I have to search out the dentist, or will they know who will be available?
Are you talking about the $500 dental service that United will be offering? Is your mother with United?
Yes, she is. Very happy with them.
Well, I don't know that they'll be directly knowledgeable of it. We hope they will be, but your mother and you will have that information to share with the nursing facility.
Okay. Thank you.
Yes, I have a question regarding the WRK program, the Opportunities and Rewards for Kansans. Can you tell me if Aetna's coming on board, do they currently have specialists who are trained with the WRK program, or is this something new for them?
It is new, but our staff are actually going to be training Aetna this week, next week, on the work program. So they will be trained up and understand, you know, what they need to do as far as working with folks who are on the work program. Thank you.
Again, if you have a question, I'll need you to raise your hand up high. It's a really big room, and they'll make their way back up.
Back up a little bit. A little bit ago, you talked about the phase out the TCM, targeted judge management, and go to the community services coordinators. But is there going to be some training on that?
Yes, that'll be part of the whole process, that the MCOs and the state will develop training for the community service coordinators, but there'll also be education for the members.
That's what I'm concerned with.
Yeah.
When will that take place?
Well, we don't know yet.
Okay, that's the part that I'm going to be,
Right.
me and my wife are going to be concerned with.
Right. And I should just say, this is a change to KanCare, and the legislature basically told us we could make programmatic changes to KanCare prior to July 1st of 2019. So that's why it's not happening now. And we'll be working with folks to bring that online mid-year in 2019.
I know it's been ongoing for at least a year or so, phase out the targeted case management.
Right, and as I said, the IDD population will be the last population that we move into that.
Say again? Thank you.
The IDD population, folks with intellectual and developmental disabilities, will be the last population that we face in.
Vincetta, if you can get up here, way up at the front of the room, we've got a question. He's coming.
This is a question about the foot care that's supposedly offered. Whenever I've gone online to try and figure out what they'll actually cover, a lot of times it'll say medical necessity, like if they have diabetes or something like that. My sister has fungus, which means she has really thick toenails, and it's really very, very hard not to just to trim them. So she needs to go to the podiatrist every 61 days. Is that covered? Not covered? Are there restrictions?
I don't know if that particular thing is covered. My recommendation is that you call customer service at the MCO and ask.
They're on, I see you up here in the orange shirt, and they're on their way with the microphone.
So I wonder if you could clarify the TCM, are you going to totally phase out case managers? And I guess I'm confused about what you're saying about that, how
The service itself may be phased out. The folks who provide it could be providing community service coordination. Yeah, which would be defined more broadly and allow them to do things that they can't do now and get paid.
So their role would be expanded if they choose to continue in that, they'll expand into that other area. Okay, so we just met with all those people, so don't want to lose them.
Vincetta, right over here.
Something that comes up on all the time with me and my boy is the fact she talked about the foot fungus. Now, his primary doctor has said if he lets it go and it's not taken care of, there's a good chance that he'll lose his toe and could be even more. The other thing is the norm person is having hard times getting into their doctors. I have my last appointment, they can't get me in for 2 months. You know, and part of that has to do with the cutbacks that the hospitals are going through. So, you know, we need to push more for the hospitals also, so that they will be able to provide. As far as his ear, nose, throat doctor, he will only see him to check his ear and do the surgery but they no longer can do the checking was there, and the audiology part. And he said the reason for that, for them to drop it, is because they had one time put 5 secretaries on just covering case management and stuff. So, you know, it's, some of the doctors would like to, just like the one we came from Topeka. He said, Randy, I can't do it because I can't afford it. You know, I'm an individual. I'm not Topeka ear, nose, throat, or someone like that. I'm, you know, my own business, my own practice. So there's some to be, you know, to be looked at. And I just feel case management, that's generally who I deal with, is the cases, but his case person. They seem to be able to give me the answers more than some of the others.
Thank you.
That's one back here.
I just want to follow up with the question that Gal had before, and I wanted to clarify. You had mentioned that the IDD will be the last population phased in, and that will take place spring of 19.
No, that would take place at the end of 2019 into 2020.
Okay. Will we as recipients or our families as recipients be notified about that meeting for input?
Yes. We'll have plenty of notification about the stakeholder group and what's happening.
Thank you.
And Vincent, behind you, I see an arm. Oh, I'm sorry.
It's bad when he remembers me from a couple of meetings ago. The question that I have too is, who are the community service coordinators going to work for? So right now we have our care coordinators who work for the MCOs. We have our TCMs that actually work for us. And so they fight for us and fill out paperwork for us and do all that for us. So if you're kind of getting my drift here, isn't there a conflict of interest if I have a care coordinator that needs to work for us that's employed by Aetna or Sunflower, and looking at the budget, the bottom line, what services we can cut, what we can't cut, things like that. So that is a very scary line for us of who's actually working for us and who's actually working for our loved ones. And then the other part is what's happening with the CDDOs.
Okay, let's unpack that a little bit because you had several things there. First of all, when you talk about the budget, the MCOs don't set the budget, the legislature sets the state budget. So how much money we have is determined by the legislature. They allocate money to KDHE, which then allows us to pay the MCOs. Second, targeted case managers now contract with the MCOs and then bill the MCOs for that service. The same would hold true for community service providers. They would be working in an agency in the community that contracts with the MCOs to be paid for the service they're providing you and your loved one. And as far as the CDDOs, they'll still be around. They can be community service providers if they choose to.
Thank you. And looks like we're behind Vincent with Zane.
I have a two-part question, and this is kind of general. And I ask it because it's kind of a loaded question, but it's a political year, and many times as taxpayers we find that we get more immediate answers in a political year. But
just so you know, I'm not running for
I know you're not. I'm not blaming you. But I just want to ask you a couple of things. One is there an overall long-term plan for your department and for what it covers in the state? And secondly, is there a group, who is the group in the state that evaluates the efficiency and thoroughness of what we have now against what we had before when we privatized all this? Those are my two questions.
Okay. Well, first of all, KDHE's been a state department for many, many, many years. Kansas has been in the Medicaid program since shortly after Medicaid came along in 1965. So Medicaid is here to stay. The form that it takes, whether it will continue to be all managed care through KanCare, I'm not a fortune teller. I can't see into the future. We're signing contracts with these MCOs that are 5-year contracts. Essentially, they're 3-year contracts with 2 1-year extensions. So at this point, the state is saying we're in managed care. We'll continue with managed care with these 3 plans. And as far as oversight, we have the federal government. If you're interested in reports that we submit to the federal government, they're all online. We have quarterly and annual reports that look at a variety of things, from the number of grievances and appeals that are filed and what type, for what purpose. There's quality information out there. There's a load of information on the KanCare website in those quarterly and annual reports. We also are audited annually by the Legislative Post Audit. We have a single state audit that occurs for KDHE and a lot of other parts of state government. So there's a lot of oversight. I can't speak to what's going to happen in the future. I can only tell you that what we're seeing going forward is KanCare as managed care.
I don't think you quite answered all my questions. Who are the people in the state? Is it the governor? Is it the legislative committee? Who looks at what you do? I mean, most of us work organizations where we have a chain of command that looks at what we've had,
Well, obviously,
changes we've made, and whether they're better than what we had before. We used to have county control where we could go to the county. Now we go to a KanCare office and they can't really help us. We get referred to the state. And particularly for counties unlike Johnson County that are far from Topeka and far from lots of medicine, the doctors, they're at a disadvantage. Having those people on the ground that knew how this system worked was a real advantage. And I'm just asking, who looks at that to say whether what we have now is significantly better than what we used to have?
Okay, and I think you're talking about the former SRS offices and DCF offices. And now we have the clearinghouse, and so your question is, who's looking at that? Everybody's looking at that. The legislature, the governor, the federal government. We answer to all those people. We're an executive branch agency, so our secretary answers to the governor. As a state, in the Medicaid program, we answer to the federal government. And the legislature overlooks everything we do. They're the ones who fund us. We actually have a KanCare Oversight Committee. It's a joint legislative committee that meets throughout the year, not just when the legislature's in session. And we have to constantly report to them. So I can tell you that everybody's looking at it. I can also tell you that we're doing everything we can to make changes, to try to improve the system in terms of eligibility and how quickly we can get eligibility done.
Lindsay, go ahead.
Would you please clarify who the community coordinator people will be accountable to?
Community service coordinators will work for a community agency that contracts with the MCOs, just like other providers contract with the MCOs now. We are ultimately responsible for what they do and what the MCOs do, because we contract with the MCOs, who in turn contract with the community service coordinators.
Zane?
Hi, I'm 22 and some of my medicines are like really, really expensive. Is there like a thing that helps people pay for their copays on the medicines?
Are you a KanCare member?
Yeah.
Okay. You should not have copays if they're covered prescriptions.
Like I have a toothpaste that I'm supposed to use and it's $40 because it's not covered under my insurance.
Well, every insurance doesn't cover some things, and if it's an over-the-counter insurance or over-the-counter toothpaste, does your doctor write a prescription for it?
Yes, ma'am.
Okay, come see me afterwards so I can get that information and we can take a look at it. Okay, thank you.
Okay, so, sorry, but are the MCOs going to be directing what the community coordinators do?
I'm not sure what you mean by directing. The state will define the service. The state will define what community service coordination is. And if community service coordinators are providing that service, they can bill the MCOs and get paid for it. Now, the MCOs with every provider can audit any of their providers. They go to doctor's offices, they go to hospitals, they say, let's see your records, let's make sure you provided this service, let's make sure that you have all the documentation. They will do that with community service coordinators like they do with every other provider.
He's on his way up here with the microphone.
Well, I'm going to do 30 seconds.
It might not make it, it's a tight room.
This is going to sound like a dumb question, but my son has home-based services, and it's a self-directed. Who or what entity is the community service coordinator? Is it the person that directs and pays the PCAs? Or just, I don't quite know what you mean by a community service coordinator.
Well, we don't have any yet.
Oh.
And we will define that service, but the role of the community service coordinator is to help coordinate care, to make sure that folks are getting the care that they need, help them with things in the community.
Well,
Is your son, he's on an HCBS waiver?
Yes.
Does he have a physical disability?
Yes.
Okay. So at this point, he doesn't have a targeted case manager. Because that population doesn't have targeted case management.
Well, I'll just say this, and this may be appropriate for later, but one of the crying needs, whether you use a self-directed or an agency, is finding people. It's almost impossible. You know, Lathan is particularly difficult, and I'm just wondering if there, with this community service coordinator or somebody else who could get involved and develop resources to find PCAs.
Well, that's a bigger issue. Personal care attendants are difficult to find. It's hard work. It's not paid well. And it is an issue across the state, not just in Olathe or Johnson County.
I'm just wondering if you're going to try to do something about it.
Well, the community service coordinator role would not be to, build networks. That's not their function, but they could certainly help search for personal care attendants.
Okay, thank you.
Did you have one?
Okay.
Back at the, or I'm sorry, instead of back at the table, you have been at the Oh, I'm sorry.
Building on his question, the previous question, what is the state doing to help entice workers coming into the system to help the participants, our children, our family members, our loved ones?
Well, I do know that United, the CEO of United has pulled together a group to start talking about how we can do that, particularly in terms of trying to build a career path. You know, for nursing, a lot of people start out as a CNA, a certified nurse aide assistant, or a certified medical assistant, and then might move into an LPN and then an RN. So Kevin Sparks, who is the CEO at United, has pulled together a few folks to start having that discussion. How can we do that in Kansas? What's a good way to do that?
10 years ago, that was the process, because that's what we came to Kansas with our son, who's now 18. Now, the nurses are going straight from LPN school straight into the RN. They're not stopping. They're not going into home care while they're continuing getting their RN. They're just going straight bullet and then going straight graduation to facilities because they're paying the money and they're hiring. They're getting the benefits of the facilities. So they're telling the state and all of us, thanks, but we gotta take care of us, and this is where we get the better deal.
Well,
How is the state gonna compete?
Well, it's tough.
It's not competing.
It's tough to compete without money. And, you know, as I mentioned, the legislature decides what we can spend in Medicaid. And we have to cover the entire program for 400,000 people with what they give us. So there are things we don't cover. There are rates that are low. You know, it starts with lobbying your legislator, your local legislator, to say, you know, we need more help in this area. There's a lot of need in Medicaid, and there's not a lot of money to spread across it. I mean, people talk about our program being a $4 billion program. It is, but it serves 400,000 people, covers a multitude of services, and there are things that we don't cover, there are things that are not paid well, and that's the reality.
This is not a new problem.
No, it is
And
not.
this problem is not Brownback's problem,
No.
because it started before.
It is not, you're right, and it's not a KanCare problem. You know, Medicaid, across the nation, Medicaid traditionally pays lower than other health insurances.
Thank you. Thank you. Next question.
My question, I still have a little difficulty understanding why we're going from target case management to community service coordinators. Understand that the coordinators will be doing more services than the targeted ones are now. But it seems like they're going to be helping a lot more people, have a lot more clients under their umbrella. Our son is not verbal, and you have to know, his case manager knows him. If somebody is out there working with 500 people, they're not going to know our son what his needs
No,
are.
and we won't have caseloads like that. In fact, we've had conversations about one of the reasons that we want to go to community service coordination is to have more people spread across the state locally. Some of you may remember that we used to have targeted case management for a lot of populations prior to KanCare. Some of those providers who provided that service may be interested in doing community service coordination. That's one of the reasons we're not going to do it immediately. That's one of the reasons we're phasing it in. That's one of the reasons we're doing the IDP population last. We want to make sure that we have enough providers, if they're well-trained, that they understand the populations they're going to work with, and that they don't have huge caseloads.
I have a question regarding the times here. It lists 1 through 3 p.m. providers and 6 to 8 members. Is that going to be an all-day event? Or?
No, they're just like these meetings. There'll be 2-hour meetings. So provider meetings will be in the afternoon, a member and family meetings in the evening. So from 6 p.m. to 8 p.m.
So one does not have to attend the provider?
No, you do not need to attend the provider meeting.
Good questions. Thank you. Other questions? Raise your hands up high. All right. Vincent, up here towards the front of the room. He's on his way to you.
I was just asking him, who are the providers?
Who are the providers?
Yes.
Providers are all the folks who actually provide the Medicaid services. So doctors, hospitals, HCBS providers, pharmacists, all the folks who are doing the actual services that get paid by the MCOs to do those services.
Does that include the agencies?
Yes.
Okay. I guess that's the only question. I had another one, but that's one of the things that, I was just kind of wondering who was at that. Because there's a lot of things that I'm saying, I don't know if we've lost excellent people due to, like you say, the money crunch, and they were trying to do the service that my son was supposed to be getting, but they had them running all over the state of Kansas doing other things. And it's hard for, if you just sit down and do a timesheet for one individual and take care of one person, that's quite a bit itself. So you've got this provider that's not only supposed to be answering my needs and the paperwork and keep on top of everything, but you've got them running, doing 2 or 3 jobs that, and I understand we're short staffed, but there also is that burning it out stage that they're saying, well, now I'm no longer going to be there because, you got one person doing maybe 3, 4, 5 jobs.
It's hard work.
Did you have a question?
I just have one other quick question on the WORK program. As you talked about the community service coordinators, that will not affect the ILCs, is that correct? There'll still be ILCs?
No, eventually they will move into community service coordination, but the ILCs can become, an ILC is independent living counselor, they can become a community service coordinator. But they would be filling the same role with the work population.
Okay, thank you.
This has to do with, my sister has Medicare, she has GEHA supplemental insurance plan, and she has KanCare Medicaid. Unfortunately, if Medicare doesn't pay, the others don't want to pay either. So it seems like we're between a rock and a hard place. It's like, what's the point of having it if when Medicare denies paying something that the others won't?
Well, it shouldn't just be out of hand that Medicaid doesn't pay if Medicare doesn't. There are services that we cover that Medicare doesn't. And we're required, of course, to pick up the 20% that Medicare doesn't pay for folks like your sister. I would have to know what the services are. It may just be something that we don't cover, and Medicare doesn't cover it either.
What it is that Medicare may not cover it, but their supplemental plan will, but they won't pay if Medicare won't pay.
Oh, well, now
So
you're
is that just very
you're beyond my expertise. Because talking about Medicare supplement.
Surely you know of those circumstances, right? That would be the case or not, or?
Honestly, I don't know. I don't, I work in the Medicaid world, not in Medicare supplements. So you'd have to see what the supplement covers. But it is to supplement Medicare, so it may not cover something if Medicare isn't going to cover it.
Well, it's not a Medicare supplement. It is GEHA, which is the government employee health insurance.
Well, again, that's not the world I work in, so.
I'm just curious as to why, just because Medicare has to define what everybody else pays, that just seems not fair.
Well, Medicare doesn't define everything, but it obviously has some connection with the government health plan.
Yeah. Well, it was medical plan.
See a hand at the very back? Okay.
Is there an office in Johnson County if I have questions about how to fill out the paperwork for my mother? Who is on Medicaid now, but, when it comes time for renewal and stuff, if I have questions, who can I ask?
Is your mother in a nursing facility?
Yes, she is.
Okay, talk with Russell, but there are, for nursing facilities, there are dedicated staff. There's not offices in every county, but there's dedicated staff at the clearinghouse who are assigned to particular nursing facilities. So your mother's nursing facility should be able to connect with a particular person at the clearinghouse to help with that.
Okay, thank you.
Or the ombudsman can help with it. Yeah.
There's an opening to office for the ombudsman.
Yeah.
In case you didn't hear that, the comment was that there's an OLA, the ombudsman's office, and the ombudsman's office can assist with that situation.
I just wanted to make an observation that 11 programs have closed in Johnson County in the last year for either residential day or case management services, and only 3 have opened. And with 6 school districts spilling their special needs population into community services, where where are we going, where's the leadership in our community and at the state level as an incentive for program development, helping them find their way in creating day services, residential. The residential services are at capacity. There are no available residential services and community-based services in Johnson County. And if it's happening here, I'm aching for rural Kansas as well. So I guess my observation is we've lost 11. Only 3 have opened. We're looking at an agency that wants to decrease costs, but our population is increasing, and most of them will live a long life. So it just doesn't, there's a disconnect, but I'm wondering at the state level, what are we doing to help create and support the creation of programs to meet the needs of this population?
Well, unfortunately, Medicaid, the federal government doesn't allow us to use that funding to bring up businesses. So just as we can't, help a hospital open up, we can't help a residential service provider open up. Once they're open, they can enroll and be paid. But we're not allowed to use Medicaid funding for that purpose. I would encourage you to work locally with your CDDO and with your education, your school districts, to think about how they can help, bring some of those up online. The other thing to think about is, does everyone need that level of residential service? Can there be other services that would help, that are paid for, that maybe aren't as resource intensive, that wouldn't necessarily require, a group home or bricks and mortar, but, a way to support folks in, apartments or other settings that maybe, obviously some folks need more staff time than others. But look at being creative as well. I would also encourage you to think about approaching health foundations. Oftentimes, health foundations won't grant money for sustained activities, but they will help for planning or bringing something up if you can, find funding to support it. So, there's foundations here in Kansas City. There's the Reach Foundation, the Greater Healthcare Foundation of Kansas City. I may have gotten that backwards, but we have 6 or 7 health foundations in Kansas. As families, you might want to band together, work with your CDDO, approach some of those foundations and see what they can do to help as well, to sort of get things started. And as I said, once something's up and running and we can license it, or KDAS can license it, then we're allowed to pay for it.
I have a question. My husband is in a nursing home in Topeka, and when we try to get information on his case, which has been ongoing for over a year, do they have a specific case manager that we can speak with that will handle it every time we talk to someone, or is it just random?
No, that's one of the issues with the clearinghouse. There aren't case managers for cases. If you have information, if you've got his number and the date you applied or renewed, see Russell afterwards. He can check on it for you to see what's happening with it.
But they don't tell us enough information. They just tell us it's in the works and we can't find out anything more than that.
That's right, because the folks that you talk to are the customer service folks. The people who are working the applications are working the applications. They're not on the phone, so they can't answer those questions. And the customer service people can't really answer them either. They're not working the application.
I went to the KanCare office in Topeka and spoke with a lady, and she gave me the same basic, we're working on it. And then someone called me who was not the person I saw and said, we're working on it, but there's this problem. And they didn't give me any specifics. And we're having a problem about having 2 mortgages, which we're trying to eliminate, that they won't finish out the application or status, I guess, until we get this mortgage thing cleared up. And I can't get any other information except just fix the mortgage problem, and that's all they will tell me.
Okay, see Russell afterwards, he can help you with that.
Russell, will you leave your hand really quick so we make sure she knows who to talk to right up here in the blue shirt? He's leaving his hand for you so you can snag him after we're
guy in the
talk
blue
to
shirt.
Other questions? All right, Zane, I've got a hand up here at the front and center in a blue shirt. Will you raise your hand up high for me so we can make sure we find you? And then Vincent away in the very back.
On a covered benefit, who determines their criteria? The MCO, the federal government, or Kansas, how you qualify for the benefit? You have a state benefit, let's say a mental illness residential. Does the MCO get to set the criteria for you to qualify for that? Or is that something you do with the federal, you follow federal government guidance?
It's actually a combination. So for every healthcare code, that's...
Is it different with each MCO or the same? Meaning that you might qualify under one MCO for the benefit, but maybe not in the other, or do they follow all the same criteria?
Okay. So it starts with the federal government deciding what a code is for. And typically with that, they'll say who can provide it, what type of provider, and criteria like that. So then, if we cover that service, we define it in policy, and that is shared with the MCOs. All the MCOs have to cover that service. Now, in some cases, they apply what's called medical necessity. And that means that they look at every individual, and medical necessity is individualized. So, if I break my leg and Russell breaks his leg, we might not get the exact same treatment because there might be something slightly different about my leg break than his. And they would apply the best, clinical guidelines for that broken leg. All of the MCOs use guidelines that are either Milliman or Interqual. And those are set for physical health care and for many of the behavioral health care codes, not all of them. So they can take what we say has to be covered, and then they can apply medical necessity and use those clinical guidelines on an individualized basis to say, you qualify, but you don't for this particular service.
And then who gets the appeal?
The individual can appeal.
If you appeal it, who gets the appeal?
Well, first the appeal, if you're a member, the appeal goes to the MCO, but you also have the opportunity to have a state fair hearing at the state level with the state.
So there's no arbitrator, or it never hits the federal level?
No. So it goes to the MCO, they can review it, but you can also, it's not called an appeal to the state, you can file for a state fair hearing, and that comes to us, and we have an Office of Administrative Hearings. It's an independent entity with administrative law judges who review and hear those state fair hearings.
My question is about the change to community service coordinators from TCMs. Is this expected to be a cost-neutral change, or is this expected to cost more, or will it cost less than the previous model? And another question I have is regarding the IDD waiver. Is there any effort currently, or is there any change proposed that will shorten the wait list for the IDD waiver, which is currently at 8 to 10 years?
Okay, I'll take the first question, I'll let Brad take the second one. The first question is, we don't know if it's going to cost more, cost less, or be the same. It's going to depend on the work that we do with stakeholders, how we define the service, what we decide to pay, etc. So we're not saying one way or the other it's going to save money or cost money. We think it's the right thing to do based on all the feedback we've gotten from you all over the years about care coordination.
And on the IDD wait list, and kind of goes back to Becky's comment earlier, funding eliminates the wait list. So right now we have a cap of how many individuals we can serve on IDD, which is just about 9,000 with the existing funding that we have. So to serve more than 9,000 individuals, we would have to have additional funding from the legislature. Our agency, last year, we put a budget request in to eliminate both the IDD and the PD wait list, which the cost of that was going to be about $200 million. So we are looking this year as we prepare our budget to submit a 5-year plan that would eliminate those wait lists within 5 years. So that's something we're working on currently of what a 5-year plan would look like if we could get funding over 5 years to eliminate both wait lists.
And I'm not seeing any hands.
The Monday meeting is the same as this one. The Monday meeting at Juco. You're not doing that one.
No, that one is home and community-based waiver specific. So that one's specifically related to those renewals that are coming up.
Okay. And so if we got a letter, we should go to.
If you're interested, yes.
Okay.
I have a daughter who's been on HCBS pre-KanCare and KanCare. When KanCare was first developed, part of the reason for that, our understanding, was that it would reduce the cost of Medicaid down the road. I'd like to know if you have facts about how much it has decreased the cost of Medicaid in the past 5 years.
So I can speak a little bit to that. I know we presented to the legislature basically what the cost is. Very little of it was cost savings. Most of it was what we call cost avoidance, basically preventing the cost from continuing to rise. So we do have some data that we can provide, probably as part of the Q&A that we'll have afterwards that we can include as part of that to show what those costs would look like pre-KanCare if we would have stayed in fee-for-service, and what those costs look like today.
All right, well, thank you guys very much for all of your questions. Brad, if you want to give that mic back over to Becky. Becky will talk us through what's happening next.
Okay, so we mentioned we're having meetings in October, so look for the invitations to those meetings coming to your loved ones or to you all shortly. They're being mailed out now. I think there were half sheets on your table with more details about the exact locations of these meetings and the times, but they'll be similar to this, 6 to 8 in the evening. We're going to have more because we want to make sure we're reaching everybody when we talk about those enrollment packets. So make sure you come to one of those meetings. That's where we're going to go over those value-added services. The 3 MCOs, including Aetna, will be able to speak to you at those meetings, so you can meet representatives from each of the plans. You can ask them questions. We'll go over the enrollment packet. I'll talk more about those value-added benefits, and you can actually see a chart that will compare the 3 plans on that particular issue. If you have questions, you can call. You can go to our website and get a wealth of information, including those reports that I talked about. And we want to thank you all for coming tonight. We look forward to meeting with you again in October. And remember, if you have specific individualized questions, you can meet up with us afterwards and we'll try to help you.
And that'll conclude our session this evening. Thank you all again for taking time out of your evenings to be here. Have a great night.